Hello, hello, welcome. Well, we're getting started again just in a moment. Invite everyone to take their seats. Thank you so much. And to everyone online, thank you for bearing with us while we took this break. It's my absolute pleasure to introduce our next speaker, who will be presenting on a white paper that is the product of Solve M.E. CFS initiative and the Solve Long COVID initiative. I have the pleasure to work with Melissa as a co-author on this paper, and I am so pleased at the results. This paper was a project due to a lot of requests for data, both from members of Congress and our public policy partners and from the community itself. So using mathematical models, as you'll hear, this paper strove to understand the prevalence and cost of long COVID. Melissa Smallwood is a science technology policy researcher with a background in neuroscience, psychology, social science, and disability studies. Her current work explores the long-term policy implications of long-haul COVID-19 and enduring consequences of the COVID-19 pandemic. Ms. Smallwood is working with the Solve M.E. research team, as you know, and is a co-author on this paper as well. Other projects that she has worked on include developing a role of the national laboratory system in the early pandemic response, the public assessment of human gene editing, and the future of healthcare. Melissa, are you with us?
So yes, as Emily said, Solve M.E. and the Solve Long COVID initiative recently put out a white paper estimating the number of long COVID cases in the United States, broken down by states, using publicly available data on the number of COVID cases that have occurred in the US. So the question that we had to answer in order to get these estimates is, how do we estimate the number of people who have long COVID, given that our public health authorities are really not doing anything to actually track these numbers? So in order to try and calculate an estimate, we needed to take the number of surviving COVID-19 cases times the chance of developing long COVID from infection. So when we conducted this study and made these models, the emerging consensus in the literature is that about 1 in 3 or 30% of people who are infected with COVID-19 go on to develop long COVID. And sometimes these numbers vary between studies based on what they're measuring, how they're recruiting, whether a disproportionate number of people in the study were hospitalized versus not hospitalized. But the emerging consensus, or about the average of these studies, is 30% risk, which is a lot higher than any other extremely widespread viral illness that we know of. So that by itself is very alarming. And then our study estimated that 1/3 of people who develop long COVID, or 10% of the total post-COVID population, will develop severe or life-limiting disability, such as that seen in ME/CFS from long COVID. And again, with some of the more recent research that's come out since this paper was published, those numbers as well could be even higher. But spoiler alert, as I'll be getting into, even the most conservative estimates of the number of people who are going to be affected by long COVID absolutely blow our disability system out of the water. So that brings me to the second part of our calculation for how many people have long COVID, which is how many people have had COVID-19. And that question is a lot more difficult to answer than you would think. Next slide. So we constructed 2 models in our white paper to try and estimate long COVID prevalence using 2 data sets that are released by the CDC about COVID prevalence numbers in the United States. The first one, which is our lower estimate, is based on reported cases. So these are cases that are reported by state health departments, hospitals, other health authorities. These are often PCR tests that are being run in the lab. And then those are reported up to the CDC and compiled into a total case count. The problem with these numbers is that we know throughout the pandemic this is an underestimate of how many people have had COVID-19. Due to the fact that from the earliest parts of the pandemic, testing has been inaccessible to a significant number of people who have COVID. Couple this with the fact that many cases of COVID are asymptomatic or present as a mild cold or mild cold. And people who may be having those symptoms may choose not to get tested, but just to ride out the illness at home. And then as we've seen, particularly during the Omicron surge, and what we're dealing with now is people testing at home using rapid antigen tests, which unfortunately in many cases are not reported to state and local health authorities and therefore not reported to the CDC and don't end up in the official case counts. So given that we know that these reported case numbers, as high as they may be sometimes, are an undercount, we used a secondary data set to try and account for some of these unreported cases. And that is using the seroprevalence numbers from the CDC's Community Seroprevalence Survey. So essentially what this is a project where community testing sites are set up around the country, and people have their blood tested for a specific kind of antibody that is specific to natural COVID-19 infection. So that allows them to differentiate between infection-related immunity and vaccine-induced immunity. And for each state, these the prevalence numbers of this antibody within the sample population are combined to create an estimate of the percentage of people in each state who have been infected with COVID-19. And this returns a much higher estimate. Throughout our study, it was about twice the number of estimated cases as the reported case model. So these two estimates combined create a range of estimated COVID-19 cases, in the US up to January 31st, 2022. Assuming that 30% of COVID cases will develop long COVID with a modified reduced risk that we accounted for breakthrough cases during the Omicron surge in December and January of 2022. Next slide. So just to go over the results of both of our models. In the reported case model, we estimated that 22 million Americans will be affected by long COVID using case numbers up to January 31st, 2022. And 7.3 million people will experience potentially severe disability from long COVID. This comes out to 6.9 or almost 7% of the population being affected by long COVID, and 2.3% of the full United States population potentially developing severe disability because of long COVID. Next slide. And then the seroprevalence model, which, as I stated before, gives us estimates about twice the number of COVID cases as the reported case model, estimates 43 million Americans, or 13.4% of the population, will develop long COVID, with 14.3 million, or 4.4% of the population, potentially being severely affected by this illness. Next slide. So given these prevalence numbers, we took, in our white paper, we kind of took a first crack at trying to estimate the financial burden that this widespread disability is causing on a state level. And in order to calculate this, we used data that had been collected by the COVID-19 Long Hauler Advocacy Project that looked at the personal healthcare costs and lost income being experienced by people who had become severely disabled by long COVID and were no longer able to work at their full capacity. It meant about half of this population, they were out of the workforce altogether, reporting that they were completely or almost completely unable to work at their prior capacity. And the other half were operating at partial capacity and were employed in part-time work and had to reduce the amount of work they could do from full-time to part-time, with almost none of the participants being able to work at their full capacity. One thing that's important to note is that this data set assumed a 10% prevalence rate for long COVID from post-COVID patients, which is lower than the 30% that many more current studies are reporting, but is about on par with our estimate of 10% of COVID-19 survivors having disabling long COVID. And given the fact that these statistics did primarily represent people who are being severely affected by long COVID, we, in order to calculate the financial impact, we really used the statistics about the 10% of people being severely affected by long COVID instead of the 30%. So it's important to note that these numbers are also a drastic underestimate, since the full and long-term costs of long COVID on individuals, families, and communities, including from cases that might be less severe than full-blown ME/CFS, but still having downstream effects. All of that collectively is going to be much, much higher. Next slide. So the estimated costs of long COVID, which is just looking at the healthcare and lost income costs being accrued by individuals affected by long COVID, the reported case model numbers give a cost of $386 billion. And you can see on the map which states are most highly affected. There is a correlation with population for many of these models due to states with higher populations having higher numbers of people being affected by COVID and therefore long COVID. But our white paper does go into the percentage of the labor force in each state that is being affected, potentially being affected by long COVID.
Melissa, I'm gonna have to give you a 2-minute warning.
Okay, yeah, this next one's actually the last slide.
Beautiful.
Yep, and then our seroprevalence model gives an estimated personal cost of long COVID so far at $511 billion. And you can see from the map that the cumulative cost in each state is just gradually ticking up, with the states with the highest populations obviously bearing the highest cost, but really the cost of this is going to be felt in every state in the nation, and we are not right now in a position to deal with that.
Thank you so much, Melissa. Those numbers are positively staggering. Any final thoughts you'd like to share as we move on to our next panel?
I feel like I should say something brilliant, not good at thinking of that off the top of my head on short notice.
No problem. Your work speaks for itself.
The way in which we need to be acting on this needs to be coming from multiple angles. We need to view this not just as an individualized healthcare issue, but really as a more collective and community-based issue that is going to have ripple effects beyond the individual.
Here, here, I couldn't agree more. And hopefully the diverse expertise in this room and on this Zoom call will help contribute to that multi-angle approach to solving this global problem. Thank you so much, Melissa. I really appreciate your time. It's been an absolute pleasure working with you on this work. And all of you in the room, there's a handout that actually summarizes the white paper with a link on a QR code. And for those of you watching from home, the materials available in the room will be available after the conference along with the PowerPoint slides. So thank you all so much. Truly, truly fascinating work.